Hello everyone and welcome to my YouTube channel. So this is part 2 of the video series of ischemic heart disease, and if you haven't watched the part 1, which is an overview of ischemic heart disease, then go and check it out on my YouTube channel. So let's start with the stable angina. It refers to the substernal or retrosternal chest pain secondary to myocardial ischemia, which is aggravated by exertion and emotional stress and relieved by rest and nitrates. So what are the important features of stable angina? It's going to be a substernal or retrosternal chest pain, number 1. Number 2 important point is aggravated by exertion or emotional stress, and number 3 is it is relieved by nitrates and rest. So these are very important features. So the pathogenesis include it is due to ischemia due to fixed atheromatous stenosis of more than or equal to 1 coronary arteries. So this is ischemic heart disease pathogenesis. You can see the 3 layers of artery, adventitia, media and intima, and there will be due to risk factors which I have already discussed in the part 1 of the series. So due to all those risk factors, there will be injury to the endothelial lining of artery, and it will lead to inflammation and lipid deposition and smooth muscle proliferation, and there will be formation of atheroma. The atheroma may enlarge in size and may obstruct the vessel, or it may rupture, which will lead to platelet aggregation, and there will be thrombus formation. So thrombus may further lead to blockage of the vessel, and it may even lodge and form embolus. So these all I have discussed in the part 1, so you can go and check it out. So the clinical features include substernal or retrosternal chest pain of 5 to 15 minutes duration. So it's always less than 30 minutes, it's never more than 30 minutes, and it is relieved by rest or nitrates, aggravated by physical exertion, heavy meals, cold exposure or intense emotion. Pain may radiate to jaw, neck and left arm. Pain may be associated with nausea, vomiting, sweating or lightheadedness. So these all are the symptoms with which the patient may present to you. So the most initial investigation that we will perform is resting ECG. It is the best initial test, and it will show signs of myocardial ischemia, that is ST depression and T wave inversion. It is usually normal in patients with a stable angina. Serial ECG can be done every 15 to 30 minutes, and serial troponin levels can also be done. So troponin are cardiac enzyme which are raised in ischemic heart diseases. So, another important test is exercise ECG, which is also known as exercise tolerance test, and it is sensitive in the patient who are able to increase their heart rate up to 85% of the maximum heart rate, and the maximum heart rate can be calculated by the 220 minus their age. So the exercise tolerance test involves recording ECG before, during and after exercise on the treadmill, and the patient who have the positive stress test should undergo cardiac catheterization or angiography. So the ST wave depression can be seen in these different type of morphological patterns, but these all are ST wave depression. Here you can appreciate ST wave depression and T wave inversion in lead ABR, V1, V2, V3. So the signs of myocardial ischemia that we have to look on ECG are planar ST depression, which will indicate ischemia, downsloping ST depression, which will indicate ischemia, and upsloping ST depression, which may be a non-specific finding and it is normal. So exercise ECG depends on 2 factors: the patient is able to exercise or not, and if there are any baseline ECG abnormalities or not. So these are the ST segment depression that we have to look on exercise ECG: upsloping, downsloping and horizontal or planar. So the horizontal and downsloping one will indicate ischemia, however the upsloping one may be normal and non-specific. So the exercise tolerance test has some limitations, like what if there are baseline ECG abnormalities, or what if the patient cannot perform exercise. The baseline abnormalities which are already present in ECG of a patient and which always appear in the ECG of the patient whether the presence of symptom or not. So if they are present, that they can interfere with the detection of present ischemia. So in such cases, how do we detect ischemia? We can perform exercise thallium scan or exercise echocardiography. These both can detect ischemia. And what if the patient cannot exercise? So in such scenario, we will perform pharmacological thallium scan or pharmacological echocardiography. So the patient who are having baseline abnormalities of ECG and showing equivocal exercise tolerance test, so we can perform exercise thallium scanning in those patients, and those who are unable to exercise, we can perform pharmacological thallium scanning by giving diparadimol. And we will obtain different CT scans of the myocardium at rest and during the stress after administration of IV radioactive isotope. And this perfusion scan will detect perfusion defect. In cases of reversible ischemia, the perfusion defect will only be seen during stress and not seen on rest. However, in case of irreversible ischemia or infarction, there will be a perfusion defect during stress as well as at rest. So you can see in this picture, after giving IV radioisotope, you can clearly see the perfusion defect. So with the stress, there is a perfusion defect which is present and marked with yellow arrow, and on rest there is no perfusion defect. It means it is a reversible ischemia. Stress echo is an alternative to myocardial perfusion scanning. It uses transthoracic echocardiography to identify myocardial ischemia and infarction. The type of stress we are going to give is exercise echocardiography or pharmacological using dobutamine for those who cannot tolerate exercise. And the interpretation will include, in the cases of reversible ischemia, there will be decreased wall motion during exercise only, and in case of irreversible ischemia or infarction, there will be decreased wall motion during exercise as well as at rest. Coronary angiography is another investigation, and it is the most accurate test for detecting coronary artery disease. It will detect the anatomical location of coronary artery disease, and it provides information as to which procedure is preferable, either CABG or PCI. So the management will include lifestyle modification, smoking cessation, weight reduction, regular exercises, decrease intake of saturated fats and cholesterol. The cholesterol should be less than 200 milligram per day. Control blood pressure, treat hyperlipidemia. So you have to do, how you will treat hyperlipidemia? By decreasing the cholesterol intake or by taking statins, which is HMG co-reductase inhibitors, examples simvastatin, atorvastatins, etc. So after lifestyle modification and controlling of blood pressure and sugar and hyperlipidemia, then another important step is antiplatelet therapy. So we can give aspirin or clopidogrel. Aspirin is indicated in all patients with coronary artery disease and should be started with a low dose, example 75 milligram once daily. And clopidogrel is equally effective as aspirin, and the same dosage 75 milligram once daily. It is given for those who cannot tolerate aspirin. Anti-anginal therapy include nitrates, beta blockers, calcium channel blocker, potassium channel blocker, and IF channel antagonists. Nitrates, example glyceryl trinitrate GTN. It causes venous as well as arteriolar dilatation, and these agents will decrease both preload and afterload because the veins and arteries both are dilated. So both preload and afterload will be decreased. So the GTN is given orally, sublingually, transdermally, or intravenously. It undergoes first pass extensive metabolism in the liver and is ineffective orally. So the best way to give it during the angina episode is sublingual or IV. The side effects include headache and orthostatic hypotension. The beta blockers are the agents which will block sympathetic stimulation, and they will lower myocardial oxygen demand. There are cardioselective beta blocker and non-cardioselective beta blocker. Cardioselective include metoprolol, and non-selective beta blocker are propranolol. So the non-selective beta blockers, because they also act on lungs and other smooth muscles, so they can lead to bronchospasm, so they should not be given in asthmatic patient or COPD patients. So bronchospasm is a side effect. Withdrawal symptoms may also occur because of abrupt withdrawal of beta blockers, and they have a rebound effect and precipitate dangerous arrhythmias or MI. Calcium channel blockers can cause coronary vasodilation and they will decrease the afterload. Dihydropyridine calcium channel blockers, example nifedipine and nicardipine, can cause reflex tachycardia and therefore must be given with beta blockers. Non-dihydropyridine pyridine calcium channel blockers, example verapamil and diltiazem, must not be given with beta blockers because they may result in profound bradycardia. So if they are already causing bradycardia and you will give beta blockers, so it's going to be a very dangerous bradycardia. It is therefore suitable in those who can tolerate beta blocker, who cannot tolerate beta blockers, example asthma. So the side effects of calcium channel blocker include myocardial depression, heart failure, constipation, peripheral edema, flushing, headache, dizziness. These all are calcium channel blocker side effects. Potassium channel blocker activators like nitrates, these agents can also cause venous and arteriolar dilation, and unlike nitrates, these agents are not associated with pharmacological tolerance. Nicorandil is the only drug in this class and it is given as 10 to 30 milligram twice daily oral dose. IF channel antagonist includes ivabradine, which is the first of this class of drug, and it acts on the IF invert current in the SA node, and this will reduce the heart rate of the patient, so reduce the myocardial oxygen demand. The definitive managements include percutaneous coronary angiography, which is also known as PCI. It is referred to as angioplasty and it consists of both coronary angioplasty with a balloon or stenting. So the indications of PCI are acute coronary syndrome with ST segment elevation and should be considered in a single or two vessel disease. It should be considered even in three vessel disease. It is considered in stable angina to provide symptomatic relief, but it is unclear if it improves the survival in chronic stable angina. So the complication of PCI, acute complication include occlusion of the target vessel. It occurs in 2 to 5% of the procedure and it is due to occlusion of vessel by a thrombus or coronary artery dissection, iatrogenic dissection. And in chronic cases, there can be restenosis of the dilated vessel and it tends to occur within 3 months of the procedure. It is due to combination of elastic recoil and smooth muscle proliferation. Coronary artery bypass grafting, as the name suggests, it's going to be a surgical procedure of revascularization, and what we are going to do, we will bypass the stenotic coronary vessel using a graft. The grafts can be arterial, which can be taken from internal mammary artery or radial artery. The grafts can be venous, taken from saphenous vein. The arterial grafts have long-term patency than venous grafts, and the 50% of venous grafts are patent for 10 years after surgery, while 80% arterial grafts are patent at 10 years after surgery. So arterial grafts have long-term patent. The indications for CABG are 3 vessel disease with at least 70% stenosis in each vessel, and including left anterior descending, circumflex and right coronary arteries. The involvement of left main coronary artery. 2 vessel disease in the patient with diabetes. So what are the indications? We can again repeat. Either 3 vessel disease with at least 70% stenosis. Left main coronary disease alone is the indication of CABG, and 2 vessel disease in the patient with diabetes. Complications can include perioperative stroke, short-term cognitive impairment, and long-term cognitive decline. So that's the end of the lecture. I hope you learned something from it. If you do, please like my video and subscribe to my YouTube channel. And there is another video on acute coronary syndrome. Do watch it.